that chairpersons, Dr. Manohar and Dr. Shankar, to initiate the lesson. We would like to have comments from Dr. Rima also, she was there.
So, good morning, and at the outset, let me give sincere thanks to Manoria sir for giving Nagpurians opportunity to share this session. And the next topic is very interesting, that is new anti-obesity drugs, weight loss and beyond. And it will be delivered by Dr. Brijmohan Makkar, a great legendary diabetologist and excellent orator. Over to you, Dr. Makkar.
Thank you, ma'am. Thank you for very kind introduction. Good morning, everyone. I hope I am audible.
Yes,
and
sir.
You can see my presentation also.
You can make it full screen, Dr. Makkar.
It is full screen now?
No.
Not full screen, only slides in the center. Make it full screen.
Now
Okay.
it's full screen.
Now it is full screen? Okay.
Yes, sir. Yes. Please go ahead.
So, thank you, Dr. Manoria, sir, for giving me this opportunity. As already shared with you, I am going to speak on new anti-obesity medicines, weight loss and the benefits beyond. And I will be trying to finish this in 18 minutes. I don't have any financial disclosure for this presentation. We all know that weight management strategies involve lifestyle interventions, including diet modifications, physical activity, and of course, education about obesity and behavior therapy. But most of the people require pharmacotherapy to induce a significant weight loss. And if the pharmacotherapy doesn't work, we have to resort to bariatric surgery. Till recently, bariatric surgery was the mainstay of morbid or significant obesity. But with the newer drugs coming up, bariatric surgery is being used now in a lesser and lesser number of patients. Now, two new drugs that have been introduced in the global markets are semaglutide injectable and tirzepatide injectable. Both are approved by FDA for management of obesity. And currently, both are available in India also. So, I'll be restricting my talk largely to these two medications and their effects and their benefits. Now, till recently, we have been always looking at 5 to 10% weight loss, which will be, useful in reducing the cardiovascular risk factors and improving quality of life. And this we were looking at as a target because most of the drugs that we were using. Till recently, the drugs we were using were able to give you weight loss only in the range of 10 to 12%. But now we are looking at weight loss going beyond 15%, which not only reduces the cardiovascular disease risk, it reduces NASH, it leads to remission of diabetes, and NASH can reduce cardiovascular mortality and heart failure with reduced preserved ejection fraction also. Now, as I mentioned, till recently, we were looking at pharmacotherapy and lifestyle interventions, and we were expecting a weight loss going only in the range of 10 to 12%. But if you compare with bariatric surgery, we were far behind with the targets that could be achieved with bariatric surgery. But with these newer drugs, we are looking at weight loss going in the range of 15 to 30%, almost matching bariatric surgery. So what has changed in the recent past? The biggest change that has happened is the GLP-1 receptor agonist and the company, as I say, because all these molecules are acting along, on the GLP-1 GIP axis. Now, what happened was when we started learning from bariatric surgery, we found, this is an intervention leading to increased postprandial levels of multiple enteropancreatic hormones. And this led to the notion that combining enteropancreatic hormone-based therapies would be a good choice for managing obesity. Now there are multiple smart molecules which are under development, which have the capability to recognize multiple receptors, and they can have balanced or selective bias for one or other receptor, largely acting on GLP-1, GIP, glucagon, and so on. And now we are also looking at development of tri and tetra agonists or combination of GLP-1 receptor agonists with monoclonal antibodies or GLP-1 receptor agonists with pyruvate kinase activators. You know, one of the concerns with all these molecules is when you induce weight loss, you lose muscle mass. But the newer molecules that are under, study, like GLP-1 RA with PKA or MAPS, they are also looking at preservation of muscle mass. And then we are looking at silencing of some genes which are associated with obesity. And if you silence those genes using, the silencing mRNA injections, you can actually almost double the effect of GLP-1 receptor agonists. There are a number of hormones which are being investigated, which include GLP-1 RA, GIP agonism as well as antagonism, glucagon, amylin, peptide YY, and all these are being studied in combination largely with GLP-1 RA or also alone. Now we know GLP-1 RA is secreted from L cells of intestine and leads to increase in insulin secretion and suppression of glucagon in response to meal intake, thereby normalizing the glucose level. In addition, it acts centrally in the brain to promote satiety and reduce appetite, and also leads to delay in the stomach emptying, which leads to the feeling of fullness or reduce appetite. The prototype GLP-1, which first was found to act in the central mechanism or central GLP-1 receptor is liraglutide. It acts on the GLP-1 receptors in the arcuate nucleus and hindbrain, leading to activation of POMC CART pathway, thereby leading to increased secretion of pro-opiomelanocortin, leading to increased stimulation of MCR4 receptors and inducing appetite. So, decreasing appetite or inducing satiety. And the first set of studies that involved GLP-1 RA in management of obesity was the scale studies where liraglutide 3 milligram was used and showed that we can reduce up to 6 to 7% weight using liraglutide 3 milligrams in people with obesity without diabetes. Then we had the development of semaglutide and showed that as compared to liraglutide, which lowers energy intake by only 16%, semaglutide lowers energy intake by almost 35%. It also reduces appetite, food cravings, reduces energy intake, and improves control of eating, has access in brain, acts centrally as well as peripherally, works through key physiological and well-described satiety and hunger signals, and involves both hypothalamus and hindbrain. The initial development of semaglutide was the sustained studies where it was studied for use in people with type 2 diabetes, and sustained studies showed whether it was used versus placebo or as add-on to metformin or as add-on to insulin or compared to multiple other molecules. All sustained studies showed across board, if you see here, across board A1C reduction going in the range of 1.5 to 1.8%. Not only that, in addition, there was more or less 5 to 6 kilos of weight loss in all these studies. And this was statistically significant. Then we developed the oral semaglutide, and this was studied in Pioneer program, which was the oral semaglutide or Rybelsus development program. And again, this showed that not only it reduced the A1C level significantly in people with type 2 diabetes, there was almost 5% weight reduction or 5 kilos weight reduction, and 1 in 2 patients who were given oral semaglutide achieved a weight loss of more than 5%. And this led to the hypothesis that we can use higher dose of semaglutide in people with obesity without diabetes, but with other risk factors and other comorbidities. So STEP was the semaglutide treatment evaluation program where we evaluated semaglutide 2.4 milligrams in people with obesity. So step 1, step 2, step 3, step 4 all involved people with obesity without diabetes except for step 2, which involved people with obesity and type 2 diabetes. Now, interesting thing was at the end of 1 year, almost all the patients showed a weight loss going in the range of 17 to 18%, except for the people with type 2 diabetes, where weight loss was in the range of 11%. And we know from all clinical trials with all different molecules that all weight loss drugs give you a lesser weight reduction in people with diabetes and obesity as compared to those without type 2 diabetes and obesity. Now, if you look at the percentage of people achieving weight loss, almost 86% achieved more than 5% weight loss, almost 70% achieved more than 10%, 50% achieved more than 15%, and a third achieved more than 20% weight loss. Not only that, there was people who achieved more than 10% weight loss. You will see that A1C reduction was 2.2%, and the starting A1C was only 8%. So all these people came to A1Cs less than 6%, showing remission of diabetes. In addition, there was significant improvement in the cardiovascular risk factors. There was a reduction in blood pressure in the range of 6 by 3 millimeters, reduction in the sensitive CRP levels, reduction in lipids, better glycemic control, better glycemic variability, and improvement in quality of life and patient-reported outcomes. Now, if you look at the side effects, as we expect, we expect GI upset with most of the ALP1s, and that was the case. We did not see any serious adverse events. Then we, saw the development of tirzepatide, which is a dual agonist. Actually, this molecule, dual GIP-GLP-1 agonist, came into development way back. The first reports came in way back in 2011. And since then, it has been shown in multiple studies to have significant beneficial effects. So it is a 39 amino acid linear peptide, which is basically developed on the GIP peptide sequence and has a half-life 5 days, so it can be used once a week. Now, this molecule combines the synergy between GLP-1 and GIP receptor agonism. If you look at the GLP-1, it reduces satiety but causes nausea. GIP receptor agonist reduces nausea and increases energy expenditure. Also, at the adipose tissue level, it improves insulin sensitivity, improves lipid buffering capacity. So there is more storage in the white adipose tissue subcutaneously, and there is mobilization of ectopic fat from the various ectopic sites. So there is redistribution of fat, and there is increased energy expenditure with decreased food intake, all contributing to weight loss. And the initial clinical trials with tirzepatide showed significant A1C reduction in people with type 2 diabetes going in the range of 2% to 2.4%. In addition, the weight loss was also in the range of 11%. And this was followed by SURPASS program, which was this tirzepatide development program in people with type 2 diabetes. Across board, whether it was used as monotherapy or as onto metformin or combination therapy or in combination with glargine, you will see across board A1C reduction going in the range of 2 to 2.5%. And A1C starting level is 8.2 to 8.3%. Again, showing significant people achieving remission with higher doses of tirzepatide. And not only that, there was a weight reduction going in the range of 12 kilos, and the starting weight was only about 95 kilos. So giving you almost 13-14% weight reduction in people in SURPASS studies. This led to development program for treatment in obesity, which was similar to STEP program. This is called SURMOUNT program. 4 trials, 1 year duration, and people with obesity, without diabetes and other risk factors were recruited, except for SURMOUNT 2, where people with type 2 diabetes are included. I will touch upon only SURMOUNT 1 and SURMOUNT 4 here. So SURMOUNT 1 involved tirzepatide once weekly treatment, which was, there was a slow up titration. As with all GLP-1 analogs, you start with 2.5 and go on increasing till 15 milligrams. So it takes about 6 months or 5 months to reach the desired dose, and then 1 year of follow-up. And that is why you see the numbers like 72 weeks for 1 year follow-up trial. This was phase 3 multi-center randomized double-blind trial. And if you look at the results, with 5%, 5 milligram tirzepatide, you could achieve A1C reduction of 16%. With 10 and 15 milligram, the A1C reduction went up to, the weight reduction went up to 25 to 22%. Now, if you look at the change in body weight with 5 milligrams, people lost about 16 kilos, while with 15 milligrams, they lost up to 24 kilos of weight, starting weight being again 104 kilos. So about 23% weight loss. And if you look at the number of people achieving weight loss, almost all achieved 5%, 90% achieved 90% weight, 10% weight loss, 80% achieved 15% weight loss, and almost two-thirds achieved 20% weight loss, which was very significant. So if you look at with 5 milligrams, 9 out of 10 achieved 5% weight loss, and 3 out of 4 achieved 10% weight loss. While with 15 milligrams, 8 out of 10 achieved 15% weight loss, 2 out of 3 achieved 20% weight loss, which was very significant. Now, DEXA studies were done to see how much is the fat loss. So largely it was the fat loss, and smaller portion came from the lean muscle mass. But if you look at the all clinical trials or studies for weight management, most of the time you will see two-thirds weight loss coming from the fat mass, one-third coming from the lean mass. If you look at the waist circumference, there was almost 20 centimeter reduction in waist circumference in people who had significant weight loss. In addition, BP came down by 8 by 4 millimeters. Largely, triglycerides came down by 25 to 30%. HDL went up by almost 8%, and LDL also came down about 7%. Now, this study also looked at, whether if we discontinue, what happens. So all the people were given tirzepatide, escalated to maximum dose, and then continued till 36 weeks as an adjunct to reduce calorie diet and increase physical activity. And after that, they were randomized to receive 10 to 15 milligrams of tirzepatide, whichever was the maximum tolerated dose, and half of them were randomized to placebo. And at end of 1 year, almost 10% had regained weight. Uh, 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 the people who were randomized to placebo almost regained 10% of their weight. So again, showing that you need to have a prolonged therapy to achieve sustained weight loss. Now, if you look at the percentages, as I mentioned, again, almost 70% achieved 20% weight loss in this study, and more than half achieved 25% weight loss in this study. Now, how safe are these drugs? So, semaglutide has been studied in SELECT trial, which was the cardiovascular outcome study with semaglutide in obesity. And this was one of the largest multi-center double-blind randomized placebo-controlled trial where people were randomized 1:1 to semaglutide up titrated to 2.4 versus placebo added to standard of care, and people with either high risk or established cardiovascular disease. Study involved almost 17,500 odd patients from 40 countries, and India also contributed 500 patients in this study. At the end of 4 years, significant 20% reduction in 3-point MACE, which was, very significant. And the confidence interval showed superiority of semaglutide versus placebo in reducing the 3-point MACE. Based on this, the European Society of Cardiology recommended this molecule to be considered in patients with overweight and obesity and chronic coronary syndrome without diabetes to reduce cardiovascular mortality, myocardial infarction, and stroke. There was 19% reduction in all-cause mortality, 22% reduction in reducing the risk of kidney disease, and also 73% reduction in the risk of developing diabetes. Now, at the end of 4 years of follow-up, there was sustained weight loss of more than 10%, which is again statistically significant and shows that these drugs have durable effect on long-term usage. Now, another important study that was published, last year only was the effect of semaglutide in people with type 2 diabetes and chronic kidney disease, followed up for almost 3 years or 4 years plus, again showed that there was significant reduction in the first major kidney disease event, and the hazard ratio was 0.76, that means 24% reduction and 21% reduction in the first kidney specific event. In addition, there was significant 30% reduction in cardiovascular death. There was reduction in the rate of decline of EGFR slope by 1.16 milliliter per minute. There was reduction in the first major cardiovascular event by 18%, and there was 20% reduction in death from any cause, again showing significant benefits of these drugs. Now, as far as these tirzepatide is concerned, we are expecting to see the SURPASS CV outcome data at the ESD meeting in September this year, and we will know more about their long-term safety. So, to conclude my presentation, we have newer anti-obesity medications in market which are available for use, are FDA approved, are effective in reducing weight, improving cardiovascular risk, have disease-modifying effect in people with obesity in terms of leading to remission of diabetes and also remission of NAFLD in patients. Semaglutide has proven CV and renal benefits in people with obesity without diabetes. Tirzepatide CVOT, as I told you, it is under review now. It's going to be published in September. With that, I conclude my presentation. I hope I have finished well in time. I'll be happy to take any questions.
Sir, regarding the efficacy of the drug, there is no issue. Of course, it is 72 weeks, that the drug has to be given continuously. So one must see, the age of the patient, two, the comorbidity, and three, the affordability of the patient. Because if we start very early without looking into these three aspects, there is a problem of continuity. The big problem we are facing and will face in future is the continuity of the drug. There is excitement to start, there is good result, but what about the long term? Patient taking the drug on a long term basis simply because of the cost.
Sir, you have a very valid point. I understand people are going overboard using these drugs. They're finding these as magical pills. But as I showed you in the Surmount 4, that once you stop the drug, weight will come back. We know that. And it is not to be continued only for 72 weeks. It is to be continued as long as you want to sustain weight loss. And you saw in the SELECT trial 4 years out data that end of 4 years you have a sustained weight loss. So to sustain weight loss, you have to continue drug. Cost is a big challenge. I understand. Tolerance is again always a challenge. People are not understanding that there is some amount of sarcopenia which is going to happen if people are not using good protein supplementation and regular exercise, which is again being overlooked. So we have to be cautious in using these drugs. But once used properly, they are very good drugs. And we have to also understand that obesity is a disease. We are not reducing weight. We are trying to reduce sick fat in body, which is leading to diabetes, atherosclerosis, NAFLD, and so on. That is why with significant reduction going in the range of 15 to 20%, you have remission of diabetes, remission of NAFLD, reduction in CV outcomes, improvement in dyslipidemia, and so on. So obesity is to be considered as a chronic relapsing serious disease and to be treated like one, like we treat diabetes or hypertension. We initiate with lifestyle interventions and medication. We bring down the level of glucose or blood pressure to normal level. To sustain it there, we have to continue medication. Can we stop anti-diabetic medications or antihypertensives? The answer is no. Similarly, we cannot stop anti-obesity medications also.
Thank you, Dr. Makkar.
Sir, what are
Thank you very much.
Dr. Makkar?
Thank you very
This
much.
constant social media things about the WHO issuing warning off and on neon the
So
side effect.
neon was reported earlier also, and there is another study which was recently reported, and WHO has taken notice of it, and EMA and WHO both have put it on label as a rare side effect, which is seen in 1 in 10,000 patients. Now, this is not, if you have rapid reduction in glucose, again, you can have worsening of retinopathy. We know that. And even the, intensive insulin therapy also, it has been reported. But this is not similar. This is age-related degeneration. It is similar to that. Now, why it is happening, we don't know. Possibly the trial, the data that is coming from is biased data, because this data has been picked up from a center which is treating ophthalmic diseases. This has not been picked up in, a center treating obesity. So a center where people are coming only for ophthalmic problems, and they have been found, some number has been found to be associated with semaglutide, you can have a, fallacious this thing. But it is very important to keep your eyes open to look for new side effects, because these are new drugs. Ongoing pharmacovigilance is always very important whenever we are using a new molecule, and that is why I say one should not go overboard. One should use them with proper, indications and proper education of the patient, which is very important in obesity management.
Dr.
Thank
Rima,
you,
your comments?
sir.
Dr. Rima?
I'm Dr. Kubragade from
Yes,
Nagpur.
sir.
Thank you, Dr. Manoria, for giving us the chance to share. My questions are: what happened to the leptin and ghrelin level, sir? Dr. Bridgman, sir, very nice talk.
Pardon?
My question: what is the status of leptin, and what is the status of ghrelin level after starting this anti-obesity medicines?
Okay, so I don't know the answers, because I have not gone into. I don't think they have measured ghrelin and leptin levels in these studies. But experimental studies have clearly shown that whenever there is weight reduction, there are metabolic adaptations, and ghrelin goes up. And leptin is basically, it's a molecule which where we have a leptin resistance in people with obesity. So leptin is already high. Otherwise, in a normal person, once you start getting obesity, the leptin should go low and it suppresses your appetite. But in people with obesity who have, pathological obesity, they have higher level of leptin resistance. But I don't have the answer for you right now.
Dr.
Thank you
Rima?
so much. Thank you.
Dr. Rima, your comments?
Yes, sir. Sir, one of the mechanism by which tirzepatide works that differentiates it from GLP-1 analog is also the leptin modulation that has been scientifically told that it modulates leptin metabolism, which GLP-1 analogs does
Ma'am,
not.
I mentioned about that. It selectively changes the insulin sensitivity in, adipose tissue. And that is why you have lipogenesis happening at the level of white adipose tissue. So you have more storage going there. At the same time, you have lipolysis happening in the ectopic sites where fat is getting mobilized. You have appetite suppression. You have mobilization of fat from ectopic sites, and whatever surplus is left is getting stored in this white adipose tissue. So there is improvement in insulin resistance, and it also cuts down the inflammation in the adipose tissue. And that is why the leptin also improves. So all
Sir,
these things are running parallel. Yes, ma'am.
in a given scenario, now when we have two strong drugs, tirzepatide and semaglutide in the strength of 2.4 milligram, uh, how do we go ahead to differentiate which category of the patient is going to suit to tirzepatide and which to oral
So,
semaglutide?
so there is one head-to-head trial which recently we got. I think it was Surmount 5, where they compared semaglutide versus tirzepatide. They showed that tirzepatide led to significantly more weight loss in people with obesity as compared to semaglutide, and the weight loss was to the tune of 30 to 50% higher. Now, this we are talking of one parameter. But if I have to look at a patient who has high cardiovascular risk or established cardiovascular disease, I would preferably use, semaglutides because I have the safety CV outcome data and CV superiority data with that. While I'm still waiting for the data from tirzepatide. Now, once that data is there, it will be easier to choose, but I don't think there is a big issue. You can choose any of them. They both give you significant weight loss. If you are looking at much higher, looking at only 10-15% weight loss, any of them will work. If you're looking at 25%, 30% weight loss, possibly I would choose a molecule like tirzepatide.
Dr. Makkar, one problem we face in our day-to-day, some are very good responders, some are very poor responders to these new AOMs. So do you have any predictors who is likely to respond?
So no predictors. I think the reason is we have seen non-responders even in people with diabetes to GLP-1 receptor agonists, and possibly either the GLP-1 receptors in them are not responsive, or they have severe insulin resistance, which is interfering with that. We don't know the exact cause. But there are almost 10% non-responders, and we are seeing non-responders with both. I've seen both with tirzepatide as well as semaglutide.
Your comments on obesity paradox, which we see in patients with heart failure. Patients who are obese, they live longer rather than
Yes,
those
sir.
who are
This
not
is
obese.
this is a full topic. This is a full topic you want me to answer in two,
Just
2
one,
minutes.
2 lines, your comments.
So it's a obesity paradox has been observed in people who had heart failure or who had established coronary artery disease, and during their follow-up, they found that the mortality rates were higher in people who had lost weight as compared to those who had not lost weight. And there was even this proactive uh, post hoc analysis, which again showed that benefits were more in people had higher body weight than as compared to those who had lost weight. Now, exact mechanism we don't know, but I think it is more related to the central or the ectopic fat and inflammation. And people who have shown the phenomena of obesity paradox are people who had more inflammation and higher inflammatory markers as compared to those who did not have. There was a study done by Mercedes Kantan, which looked at the new onset diabetes in a large pool of 5 trials. If I remember, these are all trials with the cardiovascular diseases, and they looked at the pool data and looked at incident diabetes, and they compared those who had normal body weight versus those who were obese. And all those who were obese had lesser mortality as compared to those who were having incident diabetes without obesity. So possibly these people have a highly inflamed or very sick adipose ectopic fat, which is causing the problem. But exact cause we don't know.
Dr. Shankar, any comments from your side?
Sir, it is a very nice lecture, Manoria sir. My question is the smoker. Most of the patients, they ask rather than taking this very costly drug, they are taking use of tobacco, smoking, and because they say that they don't get appetite suppressant. So even in European countries also, the new generation, they are going for this smoking, and it is commonly seen that the smokers are very slim, trim. So what is your this as far as the Nagpur is concerned? So many girls are also smoking, and so many people from Pune.
Sir, if I am correct, the newer generation is not as pro smoking as the older generation was. And if you want to smoke to reduce weight, in fact, it can reduce you to zero because you are very high risk for cardiovascular disease and malignancies. Smoking is one, risk factor which increases the risk of almost all cancers in body. And there is not a single condition which is benefited with smoking. With alcohol, I can debate that up to 60 ml or one drink on daily basis is beneficial. I can still debate on that. But not a single cigarette any day has been shown to be beneficial. The question is, they have suppression of appetite, and once they leave smoking, they tend to gain weight. The smoking is leading to one, vascular inflammation. Second, the GI, acid production is so high that they don't get appetite, and they are high risk for gastric ulcers also. So once they stop that, it starts improving, the appetite improves. But it doesn't mean that smoking is beneficial.
So Japanese
So
people,
no way we can talk of smoking as a,
I'm not promoting it, but my question is Japanese people actually they live
and
longer
no,
as compared to
no,
Indian
sir,
people.
smokers, no study has shown that smokers live longer in any population.
So with this, we conclude this session.